If anybody else wants the background, it's there in the chat. Hello and very good evening to one and all. Here we are again with the part 2 of our Kera Grand Round. This concept of Kera Grand Round is, I would say, sort of our favorite in our entire group. It was conceptualized to have more case presentations, more discussion about something which is more pertinent to the clinicians. And that's how Kera Grand Round started. It was very well received. Dr. Paras has put a lot of work in this thing and a lot of heart on in this entire program and has come out with a wonderful program. We have a company of august panelists and we have awesome moderators and we have really knowledgeable speakers here, and we are all up there for a beautiful fiesta of knowledge. So with this thing, I hand over the proceeding to Dr. Paras and wish you all the best for this thing.
Thank you, Himanshu, and good evening to all. Thank you for joining us today, evening, one of the working days as usual. We'll try to keep this program as crisp as possible. We all know that, dry eye is such a condition that we all see these cases day in and out in our clinic, and we thought of putting up, dry eye and its mimics. Most of the hard work is not done by me, Himanshu, it is done by Bhaskar. I'm just taking a credit for that. For today's, Kera Grand Round 2, we have esteemed panelists like we have Dr. Geeta here. I don't need to introduce any of them. I'll just name them and we'll switch over to, straight away the program. We have Dr. Geeta here from Chennai. We have Dr. Vinay Pillai from Kochi, Dr. Sangeeta Wagh from Pune, and Dr. Pragya Rao from Hyderabad. As moderators, I have Dr. Bhaskar as a chief moderator, and I would be assisting him for this. What we have done here is we have divided, we got interesting case collections. And fortunately, all of them have, helped us out with, voiceover. So we would be running the, presentations. So you can shoot up your questions into the chat box and we can try to answer maximum questions as possible. So we would be spending more time on the discussions. What we have done is for this session, we have divided that into mainly essentially 3 parts. The first part would have cases on Sjogren's syndrome, its different presentations and management. Followed by the discussion. The second part would have dry eye mimics, again interesting cases. The third part, we would have a challenging case of the day from Dr. Sangeeta Wagh. And if the time permits, we would have potpourri by Dr. Bhaskar. So with this, I think I would like to invite all of you for this, very exciting session. And apart from our esteemed panelists, we have our CSI panel as a CSI, all the members as executive committee members as the panelists. So we have, stalwarts on the field. So with this, I would ask Dr. Bhaskar to take on.
A very good evening to one and all, and we can start off. The first presentation is by Dr. Priyanka, and followed by Dr. Sunita, and then by Dr. Deepti Meda, and they'll be covering various aspects of Sjogren's disease, and then we take questions like Paras has mentioned. So can you start? Can you play the first case?
Good evening, everyone. I'm Dr. Priyanka, Cornea Fellow from Shankar Netralaya. Today I present a case of 43-year-old female who presented with blurring of vision and irritation in both the eyes for past 3 years, left eye more than the right eye. Symptoms were more worse in the morning. She also gives history of joint pains and dry mouth. She was diagnosed as dry eyes elsewhere, for which LipiFlow treatment was given and had marginal improvement in her symptoms. Systemic history includes hypothyroidism, for which she is on treatment. Her blood investigations were done. RA, ANA, and CCP were negative. On examination, her Schirmer's was 1 mm in both the eyes. There were diffuse SPKs on the cornea in both the eyes. TMH was low. TBUT was 3 seconds in the right eye and instantaneous in the left eye. Conjunctiva showed minimal staining. Lacrimal gland, the volume was okay, but there were no tear flow. FCT revealed severe ATD and no reflex tearing. Investigations revealed a low TMH, low NIPUT, decreased in lipid layer thickness. Mebography showed meibomian gland loss, which is more worse in the left eye compared to the right eye. With this, a diagnosis of both eyes moderate dry eyes, level 2 to 3 DUEs, both ATD and MGD component, and secondary Sjogren syndrome was made. The options for severe level 3 dry eyes includes role of topical immunomodulators, role of topical steroids for inflammation, topical lubricants, biological autoserum drops, and tear conservative strategies. In view of severe dry eyes, patient underwent punctal cautery in both the eyes, post which she had significant improvement in her symptoms as well as ocular surface staining and dry eye parameters. Schirmer's was 11 mm and 12 mm in both the eyes respectively, post-punctal cautery. TMH has increased, TBUT has improved, corneal and conjunctival staining was absent. Comparing the investigations, there was improvement in the NIPUT, tear meniscus height, and even lipid layer thickness and in interferometry pattern post-punctal cautery. The LipiView shows that the pre-op thickness was 64, which improved to 100 post-punctal cautery. Because of an improvement in the aqueous layer, had allowed a better spread of lipid. This is revealed in the subsequent video here. Preoperatively, the tear movement is low and the interference pattern is dark gray, suggestive of low lipid levels. Whereas in the post-punctal cautery, there is an improvement in the tear movement on the surface and the multicolor pattern on interference fringes suggests an improvement in the lipid layer. Thus, our patient has dry eye disease with both ATD and MGD component. The question to the panel would be, when do you decide to use special investigative tools for diagnosis of dry eye? And the other question is, the patients with both ATD and MGD, how do you decide which to treat first? Like in this case, LipiFlow versus cautery. If this patient had not had a LipiFlow, would you have considered LipiFlow before cautery?
Yeah, we can play the next video. The next video is by Dr. Sunita.
Good evening. Thanks for the opportunity and having me here for this presentation on cataract surgery in dry eye. I'm going to present a case of a 63 years old female patient, a known case of rheumatoid arthritis with secondary Sjogren's, who was already on methotrexate. She underwent uneventful cataract surgery elsewhere and was maintaining good vision post-surgery, but complained of irritation, blurred vision, and inability to face light. The lubricants were hence increased, collagen plugs were put, LipiFlow was tried to improve her symptoms, but for the last 1 month she did not feel better and had come here for the second opinion. On clinical examination, right eye was affected more with diffuse SPK and central lipid defect, and left eye revealed a diffuse corneal staining. TMH was low in both the eyes. TBUT was 2 to 3 seconds, and Schirmer's values were 3 and 5 respectively in the right and left eye. Investigations revealed reasonably healthy meibomian glands with low TMH in both the eyes. The lipid levels were high. Patient had already undergone LipiFlow. Right eye alone parameters could not be relied upon as C factor was less. Patient had significant ATD component and hence was diagnosed with severe post-surgery dry eye level 3 DUSE with secondary Sjogren syndrome. She underwent punctal cautery and post-cautery in 3 days time alone, there was an improvement of surface staining. Defect in the right eye, which was not healing for a month, responded and healed well in 3 days time. Left eye also showed reduced staining and improved vision. Objective parameters also improved with the improvement in TMH and staining. Keratograph Myers became more regular and Shermer's improved to 16 and 15. Lipiflow values, LLTs were already high as patient had already undergone Lipiflow. So would like to ask the panel to respond on the pre-operative protocols prior to cataract surgery in these eyes, the intra-op nuances and post-op protocols. Thank you.
Thank you, Dr. Sunita. And the third case video is by Dr. Deepti. Can you play that video, please?
A warm good evening. My pleasure and privilege to be a part of this program. So today we will run through 5 different cases of primary and secondary Sjogren's and what different modalities we took to manage each of them. So it's basically going to be a pictorial run through. So the first patient was a 50-year-old patient with dry eye symptoms on all the possible over-the-counter medications. On asking, she had joint stiffness and pain. So we investigated her for collagen vascular diseases and she had a lot of inflammatory markers. Rheumatoid RA factor was positive, ANA was positive. So on referral to the rheumatologist, he started her on immunomodulation. So coming to the local management, sodium hyaluronate is a good option. Paraffin-based ointments are very symptom relieving for these patients. A course of anti-inflammatory are preferred as steroids, and an oral pilocarpine again is quite useful. And most important is to encourage them to follow the treatment given by the rheumatologist, as only a control of systemic disease can help us manage the eye better. So again, she was very good after 2 months and a very significant improvement was seen. The second patient, again with similar complaints, a 55-year-old, again symptomatic for more than 10 years and presented with gradual loss of vision with a matte cat. So her ocular surface looked like this, and after a surgery she looked this good. So what did we do? We combined her cataract surgery with a punctal cautery. Yes, an Elman radiofrequency was used to permanently cauterize her punctum. It comes with a handpiece and different probes which we can use for punctal cautery. And this is her pre-op puncti, immediate post-op and 2 weeks after surgery. And the results can be quite dramatic. So she was so happy that she immediately went ahead with the other eye cataract and punctal occlusion. So this is a very promising treatment for Sjogren's. The next patient was a 40-year-old female, again symptomatic for 3-4 years. The only positive history she gave systemically was that she was on infertility treatment and already on all possible medications with the low Shermer's of 3. So again, on investigating, she was picked up to have rheumatoid arthritis and referred to the rheumatologist for the same. For the eye, we planned silicone punctal plugs for her. The different plugs that are available today, the lower one is the soft plug by the Oasis, a very elegant OPD procedure. Anesthetize, dilate the punctum and insert this punctal plug with very satisfying results, and this is her 6 weeks post punctal plug insertion. And the happiest part was that she came after 3 months with a box of sweets saying that she had conceived. Yes, probably rheumatoid arthritis was the reason for her infertility, and once that was cautive, she immediately conceived. And coming to the next patient, this was a very elderly lady, 65 plus, symptomatic. She was an ayah or a clerk in a nearby school, and she was so photophobic that she could not even apply the drops by herself during her working hours. So we went ahead with scleral contact lenses in her. Today, with the advent of a lot of Indian companies who manufacture scleral lenses, they have become much more economical, and this has surely been life-changing for her. Our daughter applies the lenses in the morning, and once she's back from work, removes it. So again, with the advent of OCT, fitting scleral contact lenses has become much more simpler and predictable. So again, a dramatic change in her eye. And the last patient was a male, 45-year-old, again with a very bad ocular surface and had primary Sjogren's. So in him, we opted for using his own blood to make serum eye drops. So just collect the blood, centrifuge it for around 15 minutes after a resting time, and you can prepare drops from 10% to 100% depending on your indication. Again, works beautifully well in such patients and a much quieter and silenter ocular surface. So I would end it by saying every dry eye has a story to tell, and today there are so many options that you can provide for all your severe dry eye patients. Thank you so much.
So now that we are through the first three videos, we can have a couple of questions that we could ask our esteemed panelists. If I could just ask Dr. Geeta, what is the normal protocol that you would follow for evaluating a dry eye patient at Shankar Nethralaya?
Good evening to one and all. Excellent presentations by all the three presenters. To answer your question, Bhaskar, we have a dedicated dry eye clinic and a dry eye suite for all patients who present to us with symptoms of dry eye. And the protocol that we follow at Shankar Nethralaya might be considered exhaustive, but it is definitely complete in the approach to these patients. We are indeed fortunate to have the ocular surface portal. It's an application, it's a web-based application. I don't know if anybody is talking about that in the rest of the webinar, but that is an integral part of our dry eye workup. When a patient walks in with symptoms of dry eye, is a known case of Sjogren's, irrespective of whether he or she complains of dryness. These are patients who are included for the dry eye workup, which includes a detailed questionnaire, which is the DQ5, entry of the patient into the application, and then you initiate with the non-invasive tests and move on to the minimally invasive, the markedly invasive investigations. Do you want me to outline the sequence of tests, Bhaskar?
Yes.
That we
that would be
perform?
better. Yeah.
So quickly, following a detailed questionnaire, a vision check and refraction, the patient undergoes a tear osmolarity evaluation. This is followed by minimally or the non-invasive tests on the keratograph, which includes the non-invasive breakup time and the tear meniscus height. This is followed by the lipid layer thickness measurement on the LipiView. Following this, what we basically do is a Schirmer's evaluation, and this is followed by a mebography because that involves eversion of the lids. And once the patient has these investigations done, the ophthalmologist evaluates the patient for the tear breakup time and the ocular surface staining, which are done at the end of all the other investigations. Once we have done this, after we have done this, if the patient requires a fluorescein clearance test, that is done. After which the patient is subjected to applanation, tonometry, and dilatation, and rest of the ocular examination.
Thanks, Dr. Geeta. Could you elaborate on how the FCT is done? Because not a lot of people would be aware of it.
Well, fluorescein clearance test is something that we've been doing right since the onset of our clinic way back in 2005. It is not something that requires to be done in every patient, but in our clinic, we do it for every patient who undergoes any form of punctal occlusion, and also in patients with moderate dry eye and inflammation, where you would want to understand the presence of delayed clearance, which would basically indicate whether you would want to start the patient on a steroid first, or whether you would want to occlude the punctum, because when you have a delayed clearance, you would probably not benefit much with punctal occlusion in a moderately dry eye. In a very severe dry eye, in most instances, the ocular surface inflammation is secondary to the severe dryness itself. The FCT is done using the same Schirmer's strip, and it is Schirmer's that's done for 1 minute at an interval of 10, 20, and 30 minutes. At the onset of the test, a drop of paracaine is instilled in the eye along with fluorescein. If you cannot measure and instill the amount of fluorescein in the eye, then we wet the fluorescein strip and take off all the excess of fluorescein and then just stain the tear film. After which, at the end of 10 minutes, the first Schirmer's is done for 1 minute, which basically determines your basal secretion. 10 minutes later, the patient undergoes another Schirmer's for 1 minute, which indicates your tearing without anesthesia. And the final test is done at 30 minutes with nasal stimulation, which basically indicates your presence or absence of reflex stimulation. So this is the sequence of doing a fluorescein clearance test, and the test is interpreted in the form of wetting at each of these time parameters along with the presence or absence of fluorescein in the strip. Fluorescein is ideally supposed to disappear at 15 minutes following the installation of fluorescein. So in your second test, you should not ideally see any fluorescein staining of the strip. If you do, and if it persists up to the third, it indicates a delayed clearance. And at every minute, a reading of more than 3 millimeters is considered as normal.
At the same time, I would also like to ask, there are people who are working in a private setup who do not have access to fellows or the residents looking after, or sometimes even the optometrists looking after the clinical work. So how do you assess, your patients in your clinical practice quickly in a busy practice? Maybe Dr. Vinay can answer that question. Dr. Vinay?
Yeah. Very difficult to, do everything what Dr. Geeta explained now. That is the ideal setup, definitely. I mean, once you go through that, it's very difficult not to follow that. But then when you're alone and in a busy clinic, it is really, really difficult to follow that. Okay. And most of the time, in practice like mine, the patient comes after, having put something in the eye, the pressure in AT has been taken or it has already been dilated. So first visit, it is really difficult to make a authentic diagnosis or assessment. So in those situations, yes, the clinical acumen and your staining pattern does help a lot. Then the true evaluation comes the next visit. Okay, when you ask the patient to come back to you, you make sure the patient comes to you directly. I mean, doesn't go anywhere else. There, yes.
Does it mean that you call them at a special time to have, have them assessed separately, like you run a dry clinic separately on a particular day for those cases?
We've been trying to do that, but then again, in a private, practice setup, it is very difficult to have one day because the patient may not prefer that day. Okay, yes. So yeah, it's a compromise. It's a juggling, to do this or that. Yeah.
Thank you, Dr. Vinay.
The other question would be, clinically we use fluorescein for a lot of our dry eye evaluation, and you have the recent concept of tear film oriented diagnosis, which has kind of been tried to make it popular because it's easily accessible. Dr. Pragya or Dr. Sangeeta, your view on how does fluorescein help you in evaluating your dry eye patients?
Thanks a lot, Dr. Bhaskar, for a very interesting and important question. And would also like to congratulate all the presenters for excellent cases. So for me, I think fluorescein staining is the most single important test for dry eye. It gives us a lot of information. Though having objective testing can add a lot of value in terms of both allowing us to counsel the patients and understanding, being able to prognosticate and also objectively assessing. But fluorescein, I think, for me is very important because I firstly sometimes, like Dr. Vinay has told, that patient just walks in and complains to the doctor about dryness much later, and then by then there's already dilatation or a GAT which has already been done. So in such patients, I make them wait for a while, at least do the fluorescein breakup time, which is very important, followed by the ocular surface staining. And for me, lacrimal gland secretions also has now, assessing the lacrimal gland secretions, that is the DADs, has also become a very important aspect in the clinic, because sometimes our Schirmer's results are not very consistent. Sometimes they're more and sometimes they're less on subsequent visits. But having the assessment of the lacrimal gland secretions also based on the amount of volume and also the number of ducts that are secreting the tears gives a very good input. So for me, fluorescein, I think, is the most important test. And in case I find anything deranged, I also prefer to call them on another day and then do just all the non-invasive tests at a sequence, like the way Dr. Geeta had described. And also sometimes if the patient is from far off and we need to do everything, that is the most idealistic scenario, where we go right from symptomatology questionnaire and all the non-invasive tests, then minimal and most invasive tests in the complete pattern. But it just sometimes becomes very difficult in a very busy clinic also to be running the entire battery. So in such cases, I prefer them to come in two different visits.
Dr. Sangeeta, quite often we see patients who come for refractive surgeries, and the only thing which seems to be altered in them is, say, the Schirmer's value of 6 or 5 or 7. They are not symptomatic. You're not seeing any staining. How would you approach these patients with respect to evaluation and proceeding with the refractive surgery?
Thank you, Dr. Bhaskar. And so basically, I would give a lot of importance to a deranged Schirmer's, besides looking at the ocular surface, particularly the lids, the lid margin, T-bar, looking at staining like we do for all the patients. I would definitely try to treat a patient, improve on the Schirmer's before I take this patient up for LASIK. Very often I'll send them back for a couple of weeks. And I would start topical cyclosporin along with the lubrication. And there are more than one reason, besides the fact that a lot of these patients would eventually land up with dry eyes, which are really difficult, or, superficial punctate keratopathy after the LASIK for a couple of weeks. And sometimes you're struggling for more than a few weeks. It's probably because we missed out on abnormal Schirmer's. So I would definitely want to treat this, correct the Schirmer's before I take up a patient for treatment. And particularly if we're doing surface ablation, I think it would also affect the outcome. And you do find some that get overcorrected. And, when you're looking at why it happened, it's almost always the second eye which shows a slight overcorrection because you've missed a bit of a dryness which should have been treated before.
The other question would be to the panel would be, sometimes you do have a mismatch between what you see clinically in the patient and what you get with respect to an objective assessment. Because sometimes, say, like your TMH can get erroneously be measured as a high value because of CCH or conjunctivochalatic fold. So I would want the panelists to kind of comment on how much of importance would they give to the clinical evaluation versus an objective evaluation, if there is a discrepancy.
It goes without saying that clinical examination is the final gold standard of management of dry eye patients. So investigations, I believe we should all understand, is ancillary, adjuvant, and it helps us when we face a hurdle in our clinical evaluation. So clinical evaluation and our interpretation of clinical evaluation any day stands above investigative modalities. Like you mentioned, TMH can be erroneously high because of conjunctivochalasis. You could have variations in the lipid layer thickness, you need to, in fact, the way in which we conduct these investigations in our dry eye suite is in a temperature and humidity controlled environment, because all these are things which make a difference. And a variation in any of these parameters can have an impact on the test results and therefore its interpretation. And therefore, clinical evaluation and fluorescein staining is the key and the cornerstone of dry eye examination. Very good history taking actually. Once.
Dr. Bhaskar, if I may add, so I also feel while these tests are very informative, sometimes if there's reflex steering for some reason, or if there's a hypersecretory kind of MGD, or by any chance we just, even if the optometrist, especially in the kind of setup that we are, if they worked up and they've pressed on the meibomian glands, they can give false high values of the LLT or the TMH. So those things I think should again be interpreted in correlation with what we see clinically, what the patient is complaining of, and probably repeat the examination if everything doesn't fall in place. And also I feel the way we've been capturing scans, I think they should be very standardized. Sometimes the patients are opening their eyes much wider and sometimes much narrow, and I feel that also impacts the way we calculate LLT and TMH, because the area on which the tear film now is distributed is again different. So I think being able to standardize the way we're taking tests and also being able to do it before any other intervention has happened in the eye, I think is important.
Even in terms of the lipid layer thickness, the number of times that the patient has blinked during that period plays a very important role. You can't just look at one value which is mentioned as 60 or 70, because if he's blinking 20 times in that 20 seconds, there will be some amount of lipid which is higher than what he would ideally see if he keeps his eye open. So looking at the investigation holistically is important. Dr. Paras, you can ask the next question.
I mean, like, since majority of the people are cataract surgeons and refractive surgeons, I would like to ask that how would you approach these cases with dry eye? Of course, I mean, it was very, elegantly demonstrated that underutilized tool like punctal cautery can be a very useful tool for these kind of cases. But what would be your approach and how would you plan these cases? Maybe we can have opinion from any of the panelists.
No, one question, Paras, which I was just thinking was that if you have a patient who has a lot of staining on the surface and dry and you're planning cataract surgery, should we do a punctal cautery before the cataract surgery, let the surface become stain negative, or, and then do the cataract, or should we combine it if it's borderline, or maybe some guidelines if we can get,
Absolutely. So can we have an opinion of Dr. Namrata?
I think even I was about to ask the same question, because a very nice case presentation was shown where cautery was done simultaneously with the cataract surgery, and post-operatively also it seemed to, the staining was much less. But I think ideally we should first treat it with lubricants and do a punctal cautery, and then subsequently go on to do cataract surgery. But I'm sure this must be a challenge when when it's a mild dry eye and you are in your practice and you don't want the patient to, or you don't know whether the patient is going to come back to you again or not. Then maybe in mild cases you can do it simultaneously. To my mind, I think there are no studies which have compared after a gap or simultaneous use of cautery and cataract surgery both. But it would be worth seeing, which way it is better.
So Dr. Paras, if I can just add 2 words about that patient. Yeah. So I think, rightly said, even our approach is always to improvise on the surface. This was one of the out of the box, because she had almost a hypermature cataract, an out of station patient, and getting a biometry was challenging. But she was really not looking at a glass-free vision, so we put a lot of lubricants, improved the surface a little, got a good biometry reading. But certainly the message that should go would certainly be improve the surface and then only plan a cataract surgery. So we just did something just looking at her clinical scenario, as Dr. Namrata told us.
For refractive surgery, I think I will be more conservative in the sense that until the surface stabilizes with the uh, wake up time and everything normal, I wouldn't want to, take the patient, even if it is a mild case for a refractive surgery, because you know that for sure after refractive surgery, the surface is going to it's going to become more dry.
Even for the cataract, I think what you rightly said that all our IOL power calculations are from the TFM. They are first per inch image based calculations. So anything which is improving the surface, we prefer to do first.
It is very
Dr.
clear
Paras?
I'd
that
also like to share, I
we should
have,
improve the surface first and, take care of the ocular surface problems first, recognize it early on, treat it, and then go ahead with your surgical planning. Dr. Bhaskar, we can the next
Yeah,
question.
we can just the only other thing would be I would just want the panelists to highlight on what are the post-operative and the intraoperative nuances that you would want to follow when you are advising and doing cataract surgery in patients with dry eye.
So, Dr. Bhaskar, if I may add, there are two things which I've generally noticed in these patients with dry eye. First thing is the biometry is very tricky. Sometimes we especially overestimate the cylinder, and that can be a tricky thing if we've not optimized the surface beforehand. And also post-operatively, they tend to have really bad worsening of symptoms, and then they attribute it to the surgery, which I think no surgeon wants to hear. So I think optimizing the surface is the best thing before planning any cataract surgery, and also repeating the biometry to get serial biometries, getting repeatable results, I think is the endpoint where I would generally think now this is to an extent a reliable biometry that we can go ahead with. And also another thing was refractive. For me, I've never tried to do any corneal based procedures for less than Schirmer's of 10, but I don't know how the practice patterns for everybody else is. And in fact, if it's a high myop, I would prefer an ICL over any corneal based procedures, and those relatively do well. That's my only indication where I would prefer ICL over a corneal based procedure in very, very high myops. So that was another thing.
The other thing that I just
also
wanted
in
to highlight.
cataract surgery, I just wanted to make one point, Dr. Bhaskar, that a lot of us are operating under topical anesthesia, and we're using a lot of topical anesthetics plus the povidone iodine. So if you already have a disturbed surface, I've had a couple of patients coming back in the evening with epithelial defects, and probably what we missed was a borderline surface. And so I've had some of my physician friends coming in, they'll ring me up in the middle of the night with severe pain, and they've had like an epithelial peel off. So one really needs to be very, very careful looking at the lid margin and the ocular surface before going in for. Also, the topography could be altered when you have a dry surface, right? So even in refractive cases, I think it's extremely important to look at the surface and repeat it if there's a borderline Schirmer's. And like Dr. Pragya said, I wouldn't touch a patient unless the Schirmer's was proper.
The other thing that I would just wanted to highlight was that when if you're going to be using any NSAID, then you have to be a little bit careful in these patients. You don't want them to develop epithelial defects and melts. So because of constraints of time, we go on to the next session where we will be having a couple of cases on mimics. And I would just ask the person to play the video of Dr. Prabhat.
Good evening, everyone. I'll be presenting a case of a 64-year-old female who presented with complaints of redness, pain, and foreign body sensation in both eyes since 2 months. She had undergone cataract surgery in both eyes 5 years ago. She was not on any topical medication at present. On examination, both eyes showed superior bulbar congestion, superior chalatic folds, and superior bulbar rose Bengal staining. She was treated with topical steroids and lubricants, and her thyroid function tests were found to be deranged. A similar episode occurred after 1 month, necessitating repeat therapy with topical steroids. She was keen on a permanent solution and hence was advised left eye conjunctival excision with amniotic membrane grafting. Under topical anesthesia, the superior bulbar conjunctiva was stained with rose bengal. The stained area was marked clearly with gentian violet. Conjunctiva with underlying Tenon's fascia was excised, and the bare sclera was covered with amniotic membrane with the help of fibrin glue. These are serial post-op images showing gradual epithelization of the amniotic membrane over 1 month. 2 months post-operatively, the area of excision is clearly visible between the white arrows. No chelatic folds were seen, and the amount of rose bengal staining was significantly reduced. Symptomatic relief at this point was reported to be 80%. This reduced to around 50% at the 6-month follow-up. The image shown here is at 18 months follow-up and depicts no rose bengal staining at 12 o'clock. However, superotemporally, chelatic folds were persistent along with rose bengal staining, which may account for her symptoms. Overall, the patient reported that the operated left eye felt better than the non-operated right eye. I would request the opinion of the panel on these questions. Should a supramaximal resection of the conjunctiva be attempted? When do we consider other modalities such as cautery? What do we do next in this case? And how would the approach differ in a patient of glaucoma? Thank you.
Thank you, Prabhat. And we could just play the video, the next case of Dr. Anirban.
Good evening. I will be presenting about a rare skin condition, hidradenitis suppurativa, the eye, a tricky situation. So, hidradenitis suppurativa or HS is a chronic, inflammatory, recurrent, and debilitating skin follicular disease which presents after puberty with painful, deep-seated, inflamed lesions in the apocrine gland-bearing areas of the body, such as the axillary, inguinal, and anogenital regions. So this pathogenesis begins with inflammation around the follicles, followed by hyperkeratinization and dilatation of the follicle and ultimate rupture, which ends up forming tunnels such as sinus tracts and fistulas. These are clinical photos of how it looks like. So HS can vary from presentation like inflamed lesions blood scarring as noted in stage 1 up to coalescent lesions and inflamed tunnels in stage 3. It can be managed with measures like wearing loose clothing and keeping your skin clean, as well as surgical treatment such as sinus tract excisions and deroofing, and medical management which includes antibiotics like tetracycline, doxycycline, as well as biologicals like adalimumab. HS is not considered an autoimmune disorder. However, chronic inflammation can alter the immune regulating mechanisms with loss of B and T cell control. Acute inflammation and reactivation would trigger such dysregulation, which can act as a common causal mechanism for inflammatory eye disease. So our case is that of a 41-year-old female who presented to us with blurring of vision for past 1 month and has been on treatment for HS for past several years. At presentation, she was on topical cyclosporin, lubricants, and chloromethazole. So this was a diffuse illumination photo on the first visit. Our best corrected visual acuity in the right eye was 20/30 and the left eye was 20/20 parts. On fluorescence staining, we noted the presence of diffuse punctate epithelial erosions. Schirmer's type 1 was 10 millimeters in the right eye and 24 in the left eye. We noted the presence of bulbar congestion on various gaze directions. We went ahead and did a meibography and found that there was no significant meibomian gland dropout and the lipid layer thickness was within normal limits. Coming to her plan of management, she had already been started on immunomodulators by her physician. She was on adalimumab. We decided to step up the lubricants and continue the low-dose steroids and cyclosporin. She was already on nighttime tacrolimus prescribed elsewhere, which we let continue. And we can consider her for punctal plugs upon next visit. We have asked her to review after 6 weeks and have kept a pros lens option to be kept in mind. Coming to a review in literature, Sajan et al. Noted that IED patients are usually treated with topical and systemic steroids as well as infliximab, adalimumab, and methotrexate. Fernandez et al. Noted the presence of interstitial keratitis secondary to severe HS in their case report, where they summarized the cases of 4 patients. Lee et al. Tried to assess the spectrum and treatment outcomes of IED in subjects with HS and found that anterior uveitis was by far the most common manifestation. They also noted that some overlap was present between HS and keratoconjunctivitis sicca. However, they were not able to find a definite association. They did suggest that a possible association between MGD and HS should be explored in future studies. So my question for the expert panel is, what have your experiences been with HS patients and their ocular complaints? Thank you.
Thank you, Dr. Anirban. So we go to the panel discussion for the next 2 cases. I would just like to ask the panel, the first case of SLKC, when would you decide to surgically intervene in these patients? And what would be your surgical option of choice? Dr. Vinay, Dr. Geeta, Dr. Pragya, or anybody, any of the EC members?
Yeah, Bhaskar, I have never done a superior conjunctival surgery. I've done lots of inferior, but because we normally look at the inferior area for an SLK, I think it's a bit of an overkill to do to excise that area, because that area is not permanently going to be inflamed. A lower 6 o'clock conjunctival is something which is a sort of permanent structure with hills and valleys and all that. So I would not hesitate to do for a lower conjunctival, but I think it's a bit of an overkill to do it for an SLK. I would continue with just medical management. I am a great fan of orosporin, no commercial, no financial interest. So I would put the patient on topical 2% orosporin, tacrolimus at night, and use the minimum amount of steroids that we have to do to control the SLK. And usually these resolve over time.
Bhaskar, one thing I would like to just point out there, that I think what we are looking at, the staining is the effect. It's not the cause of the disease. So we are sort of trying to treat the effect and not the cause, and which possibly may not help us at the long run. So if you remove the conjunctiva from there, of course, you'll not see the staining there. But the cause there was the friction-related trauma. And we know that we have to find out a way to reduce the friction-related trauma, whether it's the eyeball which is protruding out, whether it's a tight lid, whether it's something which you want to intervene with a lipid-based lubricant. Like I would prefer any ointment base, especially which does not have a surface toxicity. So plain paraffin-based ointment can work well. Large diameter contact lens can work. Sometimes even the oculoplasty intervention by reducing the tightness of lid can work. Floppy eyelid treatment can work, and along with, of course, the systemic workup and mild anti-inflammatory and topical steroid can work. But I think we have to treat the cause and not just the effect.
In fact, coming to the oculoplasty part, you might actually get a worsening, especially if they do a tightening of the lid for some kind of blepharoplasties as such. So you might
not tightening, not tightening, but if there is a blepharospasm, maybe a Botox, limited amount of Botox can.
So the option of a large diameter scleral, a large diameter contact lens for the time that your inflammation settles down, or for a Pros lens for a reasonable period of time. But it's also important to actually evaluate these patients for dry eye. They tend to have a reasonable amount of dry eye, which needs to be addressed as such. Surgical options ideally would be the last option that you would want to touch. And the question that he had at the end, in terms of if you have a glaucoma patient and it is not settling down, then you are definitely going to be a lot more worried about surgically touching the superior conjunctiva as such. So in medical measures, you use topical cyclosporine, or you use a combination of topical steroids, long-term ointment, steroid at night. What do you do?
Most of these patients respond well to topical steroids and topical immunosuppressive agents, but we also need to look at some systemic causes. Like, I would always investigate them for a thyroid abnormality, because that's supposed to be quite closely related to SLK. And things like the floppy lid can also aggravate, like Dr. Himanshu said, with the friction. So I think 95% of the patients are symptomatically relieved with topical therapy. And like you said, surgery would be probably one of the last options. There are some couple of references on using a cryofreeze, just a very gentle cryofreeze to the affected conjunctiva, and just followed it up with lubrication. So I would try conservative management before, because it's possible that in the area that you have grafted, the disease is going to recur unless the cause itself is not treated.
So go on to the next case, which was on hidradenitis suppurativa. The panel's experience with this, because it's a rare condition. I mean, the idea of putting it was, obviously when you're dealing with lids, you need to know the other differential diagnosis in terms of blepharitis, whether it is demodex related, everything which can affect the ocular surface. But with this particular entity, whether the panelists have any experience with seeing ocular manifestations of the disease?
So can I just take that one?
I haven't seen any.
Yeah, sure.
So my and I think our experience with HS is limited to only one patient thus far. And if I am not wrong, I believe this is the patient that we have also been seeing at Shankar Nitralaya. And my relationship with the patient goes back several years. So I've been seeing this eye from before the onset of the HS, and the pseudogerontoxon, which was seen supranasally in the left eye, is actually secondary to a long-standing VKC and an allergic diathesis that this young lady suffers from, for which we started her on tacrolimus. She was already on cyclosporine eye drops, a short course of topical steroid. And her surface changes are primarily due to, that is, the staining, because if you look at her Schirmer's as well as, like Anirban mentioned, not much of meibomian gland changes. The Schirmer's was still good, but the surface still showed staining, and which is basically attributable to the long-standing VKC and atopy that she has. And it is kind of settling down with the medications that she's on for it. The HS came in much later, and she's on systemic immunomodulators, biologics for her HS. So I would very strongly believe that at this point in time, we could probably not really correlate the HS and the surface changes in this particular patient. And it's her surface changes are probably more related to her long-standing VKC.
Thank you, Geeta. So in the interest of time, we go to the next case, which is going to be Dr. Sangeeta's case on GVHD, which is quite a challenge to manage.
Good evening. I'd like to thank Dr. Paras and Kera for giving me this opportunity to share this very challenging case that I faced recently. It's titled Acute on Chronic GVHD and the Role of JAK2 Inhibitors in the Treatment. We know that graft versus host response or disease is seen in various conditions, particularly after hemopoietic limbal stem cell transplants. Here was a 45-year-old male patient, a diabetic. He had undergone a stem cell transplant for a T-cell lymphoma in 2015, and he had been under treatment for ongoing dry eyes for 4 years. When he presented to me, he had bilateral dry eyes and dryness of the mouth. He presented with lid margin keratinization, superficial punctate keratopathy, low Schirmer's, best corrected visual acuity of about 618, and he was on frequent artificial tears, cyclosporin, and oral omega-3 fatty acids. He did pretty well with miniscleral lenses and continued his work. He was a dental assistant in his wife's practice. We also placed punctal plugs, which made him work better because the frequency of installation of the drops was reduced. He was happy and achieved 6/9 vision with N6 with a +2 add. 10 months later, he presented with unilateral redness of the right eye. He had severe pain, watering, and a sudden drop in visual acuity. He had been started on low dose steroids, where he was diagnosed to have scleritis by his primary doctor. When I saw him, he had intense congestion, purulent discharge, pseudomembranes, a large epithelial defect, almost like a epithelial peel off. Eventually, the entire epithelium did peel off, and there was a rapid worsening. There was intense peripheral vascularization noted in almost all 4 quadrants, which appeared to be like an acute limbal stem cell knockoff. The scleral lens was immediately discontinued. He underwent an amniotic membrane graft with a bandage lens and tarsorrhaphy. The frequency of the artificial tears was stepped up, and the topical steroids were also stepped up from low dose to full strength steroids. Oral steroids were administered in the dose of 1 milligram per kilogram. The left eye, strangely but luckily, remained quiet right through. We touched base with the treating hematologist to ask him for possible systemic immunosuppression as well as his opinion. And I was quite surprised when he said that this was an exacerbation of the GVHD and acute on chronic response. He admitted the patient and administered high dose steroids, 1 gram of Solumedrol daily for 3 days. He increased the mycophenolate to 1 gram from 500 milligrams. And he started him on a new JAK2 inhibitor, Jakavi, that is 10 milligrams once a day, where the normal dose is about 5 milligrams. Topical steroids, artificial tears, and very close monitoring was continued. Over the next 7 to 8 weeks, the eye quietened, the amniotic membrane started disintegrating. The pannus remained on the nasal quadrant, but eventually the vessel started regressing. Eventually, he cleared, though he always had some amount of superficial punctate keratitis. Punctal plugs that had been removed were replaced, and the patient was happy again. So this was the appearance in the acute phase soon after the amniotic membrane was placed. You can see it started disintegrating over the relatively healthy part of the cornea. And this was the eventual outcome at about 8 weeks. Ocular GVHD is seen in 40 to 60% of allo stem cell transplants, and almost 60 to 90% of acute and chronic GVHD will have some ocular involvement. Besides the eye, it also affects the skin, the gut, and the liver. Acute GVHD is seen in the first 3 months post-transplant, and beyond 3 months, they call it a chronic GVHD. Acute ocular GVHD presents in the form of a hemorrhagic conjunctivitis, pseudomembranes, epithelial peel-off, ulceration, thinning, melting, and can even cost the patient the eye. Chronic ocular GVHD is in fact more quiet, and it's the result of a continuous inflammation and resulting fibrosis. So the patient presents with the meibomian gland dysfunction, lacrimal gland infiltration causing aqueous tear deficiency, and subtarsal fibrosis, and eventually a OCP-like picture. Medical management of ocular GVHD in chronic stages, we treat like any dry eye disease, treatment of the meibomian gland dysfunction, tear replacement, control of ocular inflammation by using cyclosporin or tacrolimus. Systemic therapy doesn't seem to help the patient much. As against this, in an acute GVHD, the primary line of treatment should be intense systemic immunosuppression in the form of high-dose steroids and immunosuppressive agents. The JAK2 inhibitors prevents the activation of the host cell response, where we know that the donated host cell attacks the patient's own immune system, and the activation of cytokines causes the tissue destruction. So I found this case challenging because it was an acute GVHD occurring in the background of a long-standing chronic GVHD. The unilateral presentation of the acute GVHD again was a bit baffling, and I failed to detect this at the outset. Timely treatment with the amniotic membrane graft and the intense systemic therapy, not to mention the intervention of the hematologist, probably saved this eye. I also learned that ruxolitinib, the JAK1, JAK2 inhibitor, has been approved by the FDA as treatment of steroid-resistant GVHD. Thank you.
Very interesting case, Dr. Sangeeta, very challenging case. Before we ask any questions about that, I would just want a quick comment from Somashila. It seems Dr. Geeta and Dr. Somashila both have seen the same patient, the previous one, hidradenitis suppurativa. Dr. Somashila, can we have a comment from you? Are you there?
She was there a little while ago.
Yeah, I just saw her and I saw her comments and I thought maybe we could involve her. But anyways, we can move on to your case. As you rightly said that, I mean, why there were, uniocular presentation in your case? Could it be, medicamentosa or any other thing in your case?
So the patient was using the same medication in both the eyes, and in fact, we had given him scleral lenses, which he was very happy, and he in fact manages his wife's entire dental practice and does all the prostheses. So there was really no difference in the two eyes, and that is what I found puzzling as to why the target organ was just the right eye. And it's not that I didn't struggle. We struggled for almost 10 days trying to salvage the situation before it suddenly occurred to me that maybe we should, involve the treating hematologist. And he looked at it and, he had no doubt. He said, I'm sure this is the GVHD that is getting reactivated. So, I just went with it. And I think it was basically his treatment that really controlled the situation.
So, was
Sangeeta,
there any other organs
GVHD
which were-
asymmetric in both eyes is not uncommon. And in fact, all these immune mediated diseases, even RA or anything, when it has a severe ocular surface damage, it is usually asymmetric. It's you seldom get a melting cornea, bilateral melting cornea with RA or something. Usually it's asymmetric only. And we don't think of RA if it is bilateral melting cornea. Similarly, bilateral such kind of acute damage in GVHD cases also not very common. I do see a lot of GVHD because of the proximity of a quite big hematology center who they do quite a good number of transplant. But as you rightly said, that usually such kind of cases, like where you start seeing corneal melt or something, they're not so commonly bilateral.
I just wondered, maybe if I had a background and had, probably thought of it at the outset, would a conjunctival biopsy have given us any more information about, do they do any immunofluorescence studies? Or because I tried to look up literature and I didn't really find anything.
The GVHD diagnosis, ocular GVHD diagnosis, also clinical diagnosis is not based on any test. In fact, the entire field is based on such a skewed thing that we call ocular GVHD only after we see the damage. So they keep on coming, and if everything is fine, we keep them sending back. But these are the cases. They should be on anti-inflammatories, like whatever you choose, whether it's cyclosporin, tacrolimus, or whatever you choose topically. They should be from the beginning on that thing. We cannot wait for GVHD to show, because as you showed, like say 60 to 90%, believe me, if they live long enough, it would be 100%. Everybody has an episode of GVHD when they live long enough with these things. What are we waiting for? We are waiting for damage to occur, and then we tell them, yeah, now it's irreversible damage, but we don't start. Rather, they can start these things as soon as the treatment is done. I really don't see a reason of why we wait to start these things.
No, but Himanshu, this patient was already on treatment for GVHD for almost 5 years
No,
before this
Sangeeta, I'm not
episode.
talking about your case. I'm just talking about in general, when they do an allo transplant, they should start them on these treatment. I'm not talking about your case totally. I mean, I'm just talking in general. Then any cases when they do an allo stem cell transplant, it's better to put them on these anti-inflammatory rather than not putting them.
The only thing interesting in this case was you have an acute onset GVHD where you can have a bilateral involvement which almost behaves like an acute SJS kind of a picture with skin involvement, mucosal involvement, all organ involvement, liver involvement. This patient has been on a chronic course of the disease and suddenly flares up. Now, there was a mention of an LMK. There will be a little bit of dryness. So whether there was an area of peel off of the epithelial defect, then you have a top up of NSAID, which kind of aggravates it. And once in any of these eyes, the moment you peel off the epithelium, it goes downhill. So it is very tempting, even in an SJS patient, it's very tempting to peel off the keratinization on the surface. But the moment you peel it off, it never heals without telling you that you've made a mistake. So whether that was one reason for the unilaterality of the disease as such. And was there any other systemic involvement in the acute GVHD, whether he had liver issues, whether he had renal issues, anything in that thing which puts it in the perspective of a acute on chronic GVHD?
So there was no other organ involved. And my only worry, the only thing I wondered is this patient was on scleral lenses, right? He had used them for a good 8 to 9 months. So I don't know if something went amiss with, maybe after a while the fitting changed, and like you said, whether the epithelium did get abraded, and that is what triggered the whole thing. So probably a serial observation or a very regular close follow-up looking at the vault and the fitting of the scleral lenses in all these patients might be critical. But since he had already crossed 6 months, we just got complacent, and the patient too was, he was from away from Pune, so he wouldn't come as regularly. He would come whenever the hematologist called him for a checkup. So I think that might be the only possible trigger where, something abraded the surface, like you said. Probably the scleral lens fitting had changed, and that is how the whole cascade started. About the lid margin keratinization, there was just one thought that came to me, like, since he was happy, he has in fact gone back to the scleral lenses now. But if the lid margin keratinization is significant, this is just a thought or a takeoff from one of the cases that Dr. Ghorpade had operated. Can we use the buccal mucosa here? Is not possible because it's very dry, right? But can we take a buccal mucosa from the original donor who gave the hemopoietic stem cells, and that would probably be the best option for this patient. And obviously the GVHD is not going to attack that tissue. Nikhil, I see you smiling. You have any?
Borrow everything. That's the only way, I think.
The donor is a donor for life.
True. I mean, you could even use the liver, right? If the liver dysfunction happened, the donor could give a bit of the liver.
I just had just one quick comment. Sometimes in a few cases of GVHD that I've seen, I've often seen them to actually occur whenever the immunosuppression has been tapered, even though they've received it for quite some time. And they generally have either skin GVHD or other organs that are involved. Also, I think over a period of time, sometimes it's the sequelae that we are looking at, that because of the, just like SJS, like Dr. Bhaskar was saying, that it's probably the dry eye that has worsened the defect, and may not always be the, in general, the entire GVHD spectrum that is worsening, not in your case, but in general. I have a couple of patients who keep coming back. They have asymmetric disease. So the worser eye keeps coming back with diffuse SPKs or epithelial breakdown. And then we just manage that locally, and they tend to do much better, and without even needing a systemic immunosuppression at every event.
Are these cases
the primary the primary GVHD was acute, or it was a chronic GVHD? I mean,
No, it was a chronic.
It was a chronic GVHD because usually, like Bhaskar mentioned, the acute GVHD presents with SJS-like features where you do tend to see LMK in the later stages. But if you do see lid margin lackluster appearance or dryness, it could even be indicative of something like a squamous metaplasia that occurs in these dry eyes over a period of time rather than an actual lid margin keratinization, which can sometimes settle down once the ocular surface is made more moist after a punctal cautery or other factors. And usually, like he mentioned, it's the loss of epithelium due to some reason that just exacerbates the cascade in these eyes. Though we need to find out if there is anything like an acute on chronic GVHD that could affect so asymmetrically. But very challenging case and very well managed. The outcome was good. Thank you.
I just wanted to ask Dr. Himanshu that are these cases being informed on a regular basis for regular checkups with even an ophthalmologist, since you are working in close association with hematologists around, like? They have to be informed on a regular basis for regular checkups, isn't it? So that, I mean, we don't miss those early findings and probably, I mean, that correlation is maintained. Anybody would like to comment on that?
It's,
so anyway.
I mean, I think there should be a correlation, but sometimes for want of time or for want of whatever reasons, it doesn't happen. In maybe places like a medical college and center where you have both in the same block, it becomes easier. But in a private setup, sometimes the ophthalmologist there is not very keen to treat GVHD patients. He's more happy doing more profitable ventures in his time.
I know that, like, I mean, we treat our, I mean, patients with dry eye and systemic diseases. Like, similarly, there has to be.
We should probably encourage the hemato-oncologists to kind of at least make sure that they periodically refer patients across. So maybe that might be a good thing to convey to the oncologist from the Cornea Society point of view, at least so that we at least have a more solid database of the amount of patients who have chronic GVHD, acute GVHD, and we are able to then guide ourselves to better managing these patients.
So I see Dr. Vanati is on the chat box, and she is a co-author of one of the major review articles on GVHD. And Dr. Vanati, if you're here, can you give us your input?
She was here. She was in the chat box.
Yeah. She's typing, but maybe she's.
Can you invite her as a panelist?
Yeah, she's there.
Yeah, can you hear me?
Yes.
Yeah. Hi, I think nice, interesting discussions on ocular GVHD. This disease definitely tends to be refractory to the conventional treatments, and when they are mild, as it was rightly pointed out, we generally tend to not make a big deal out of it and always wonder why are they coming to us here. And when they have associated skin and dental exacerbations, the ocular exacerbations also occur. And ocular exacerbations, that said, can occur without the exacerbation of other systemic involvements. And generally, if you find a patient who's been quiet and then suddenly showing exacerbations, then I always get my hematologist to look at the entire profiles, including hematological, the renal, the liver and pulmonary and other parameters to see. And there is a coincidence, systemic worsening, which probably triggers the ocular lesions as well. And what is now implicated to be the cause of this refractory dry eye disease is the extracellular nuclear traps, nets, which on the surface, which induce an immunological reaction on and off, and that makes it refractory to the routine anti-inflammatory therapy which we use for these patients. That said, using biological replacements helps in these because those are rich in growth factors here. And prophylactic use of platelet lysate drops have been implicated recently. We do have the other recent ones, which I think Dr. Sangeeta nicely highlighted in a few of the in few reports, which have been said to be useful. But on and off, it is a very refractory disease. I currently have one gentleman who was very quiet, bilateral. He went in for a melt, had a patch graft, then went in for another exacerbation, had needed a penetrating keratoplasty, a 618 vision, quiet for 2 years, comes back with an infective keratitis on that eye again. The other eye was doing better with 618, and currently I'm joined back after my vacation, and I find the good eye is also gone now with a severe melt and exacerbation. So this is how some of the refractory diseases, and these patients tend to be, say, 10% of the total lot of GVHDs who come to us, and they are really difficult to manage.
So in fact, Dr. Vanati, this drug Jakavi seems to hold a lot of promise, but of course it is also fraught with a lot of systemic side effects like thrombocytopenia, thromboembolic phenomena, second cancer. So it's always best given by the hematologist.
Yes, most of the time you probably need to step up there. There's systemic immunosuppressant therapies here, and probably add on new ones. And the ocular surface therapies need to be intensified. And you probably will need to resort to surgical interventions like amniotic membrane overlays if your surface is not doing well with conventional therapy. But as of now, the latest trial which we are running is with the platelet lysate drops, and they are doing fantastically well. And our trial on using immunoglobulin G drops in such patients, especially the refractory ones, and we are almost concluding and probably will be able to look at our results in the next 6 months and share the data with you shortly. That works well as well.
Can you tell us more about the platelet lysate? Are they made in-house? Are they commercially available?
We make it, no, it's not commercially available. We get it made in-house, and we have to look at the patient's platelet counts to be adequate before we send them for bleeding. And it's our autologous platelet counts of platelets, and these are lysed plates. So it goes through our ocular pharmacology. And the difference between autologous serum and this is here the platelets are lysed. So the growth factors are more readily available for action on the ocular surface. So they tend to give you a more rapid response. And there are, I think, papers from the Japanese group and from the Korean group, which suggest that we probably use platelet lysate therapy as a prophylactic therapy before the disease worsens in patients with quiescent ocular GVHD.
Thank you, Dr. Vanati, for those wonderful inputs. And it was very nice to have you on the panel for this discussion.
Thank you, Dr. Paris.
It was a challenging case indeed. With this, the want of time, like we move on to the last part of our, grand rounds, that is potpourri, which would be, discussed by Dr. Bhaskar. Can we have his presentation, Vinay?
A very good evening. I'll be taking you through few interesting cases. This patient, who had a smile done elsewhere, presented with complaints of dry eye and was very depressed. Evaluation revealed a borderline aqueous tear deficiency with a borderline meibomian gland dysfunction, as noted by a Shermer's of 5 mm and a tear breakup of 5 seconds. His lipid layer thickness was also low, with around 50 nanometers. His tear breakup was around 5 to 6 seconds, and the tear meniscus height was low. He was diagnosed as having moderate dry eye with the probable component of Sjogren's syndrome along with the post-surgery state. He was investigated and it was negative. We started him on topical lubricants along with cyclosporin. However, at 2 months there was no improvement. He underwent a LipiFlow, after which he felt about 20% better. At this point, we revisited the history and we found out that his discomfort was more when he was working on the computer or visual display units. And we sent him to the orthoptic clinic, and he was diagnosed as having esophoria with accommodative and convergence insufficiency. He was advised in-house orthoptic exercises, and post that the patient felt a lot better, even though the tear parameters were almost the same. So the take-home message is, when the symptoms are out of sync with signs, rule out orthoptic issues. This patient was referred to the ocular surface clinic as having severe dry eye due to the lackluster appearance of the ocular surface, the minimal conjunctival keratinization, and the diffuse corneal superficial punctate lesion. However, when we evaluated him, his Shermer's was normal, and hence we went into a detailed history, and he revealed that he had gastric upset, and we referred him to an internist who diagnosed him to have chronic pancreatitis, and this probably caused the vitamin A deficiency that was responsible for the ocular surface status. Post vitamin A injection and post improvement of his chronic pancreatitis, his ocular surface status improved. This patient presented with a history of blurred vision with itching and rubbing of the eyes and was diagnosed as having allergic eye disease with dry eye and was given lubricants without any benefit. However, on closer evaluation of the slit lamp, you see these superficial punctate lesions which have a kind of a stuck on appearance on the epithelium, and these are classical for epithelial microsporidiosis, and you need to treat it for the patient to become comfortable. This patient presented with a history of exposure to a welding arc light and had a large epithelial defect with a dry looking ocular surface. The damage seemed out of proportion to what one would expect with just a welding arc induced keratopathy. We evaluated the other eye. The Schirmer's value of the other eye was also low. There was history of dry eye and dry mouth. He was referred to the rheumatologist who diagnosed him as having Sjogren's syndrome. So the take home message here was always evaluate both the eyes of a patient. And this is the last part of the presentation where I will be talking about this app that we use at SN, and that helps us document and monitor our dry eye patients. It basically includes a detailed history that can be filled by the optometrist or by the patient himself, since it's available in multiple languages. The next is the DEQ questionnaire, which is followed by assessing if there is any other ocular surface disease that can mimic dry eye. The next is a detailed ocular examination with the staining and the Schirmer's value, after which we reach the diagnostic sheet as such. Now this diagnostic sheet uses the Schirmer's, the staining and the tear breakup time to give you a comprehensive diagnosis that can be added to your electronic medical record or a case file, or can be given to the patient as a report. We find this to be a very useful tool. An important aspect is the rheumatological interface, the fact that we can see a symptom sign trend chart which tells us how the symptoms and signs of the patient have improved or deteriorated over time, helping us evaluate and treat our patients better. So just in a nutshell, the details you could get if you log on to this portal, info@ocularsurfaceportal.in, and then you can register. Thank you. So the idea of the cases was basically just to tell us that even though we look at dry eye, sometimes you need to look outside the box also to understand why the surface staining is not matching with your Schirmer's value. It's not matching with what your other clinical findings are, rather than just giving a patient a lubricating drop and asking him to come back in a month's time. Any other?
Oscar, your method of punctum cauterization, because many of us have different ways of punctum cauterization, your way, and how often do you need it?
We use the battery cautery, which is basically like a loop kind of a cautery, so that it kind of goes into the puncta easily and it burns it. The idea of a punctal cautery and for it to last is you need to basically char the opening completely so that it scars. And when you come out, you have to come out with the battery on, and you have to make it sure that the eschar doesn't come out along with the tip. If the eschar comes out along with the tip, then that puncta will recanalize more often than not. If the eschar kind of fills the puncta when you are kind of coming out, then the surrounding epithelium will grow on top of the eschar and you end up having a closed puncta. Whereas if the eschar comes out, you have a tract for the epithelium to grow in back into the puncta, recanalize the puncta, and that is one of the reasons that you end up having a recanalization. If you use a cautery which is good, which gives you good heat immediately, rather than a cautery which sometimes doesn't burn or it burns very less, it tends to recanalize if it doesn't burn. If it burns, it has to burn fast, it burns off the entire thing. You leave a black eschar and come out. That will probably be the best that you would get. We actually do a lot more of cautery than plugs. We've kind of stopped doing plugs almost for the last 15 years, unless somebody just doesn't want a cautery for whatever reason. Like we've had a couple of medicos who said that they don't want a permanent thing. They want to first try a plug before they would want to take a decision on cautery. Or we use a plug when you're using, say, a topical mitomycin for an OSSN. Once we do the FCT, if we feel that the ATD component is significant, we are reasonably certain that these patients are not going to end up having a discomfort of excess watering from the eyes. If you have done an FCT, you are also reasonably sure that you want to first, if there is a delayed fluorescein clearance with, say, a reasonable amount of tears, like a Shermer's of 3 or 4, not a Shermer's of 0, and you have a delayed clearance, that then you know already there is a stasis of tears on the surface, whether it is because of chalasis, whether it is because of punctal inflammation. So that patient you would probably want to treat with steroids, reassess the fluorescein staining, reassess the Shermer's and the dry eye status, and then decide on blocking the puncta. So we've not had patients who have had a worsening of the dry eye, like what has been mentioned in terms of the toxic tears, and people are generally a little bit concerned about blocking the puncta. The idea is, if your dryness is what is causing the inflammation, you need to address the dryness. If your inflammation is what is more and your dryness is less, then you need to address the inflammation. So that demarcation is important to know when you would want to block and when you would want to give topical steroids.
And I think it's been years since we have given topical steroids in patients of Sjogren's syndrome, unless it is really mandatory. You just treat the dry eye and the surface inflammation absolutely goes off.
The other thing I just want, sorry. The other thing that I just wanted to add, when we had the discussion on cataract and cautery, when you do a cataract surgery, you would give steroids. You generally don't want to, when you are doing a cautery, you want that area to scar. So if you're going to be giving topical steroids, the possibility of the puncta recanalizing is going to be a little bit higher, even though we don't have studies to actually do it. And we occasionally go ahead and do it at the same sitting for basic patient cannot come back again, or for whatever reasons. But ideally, you would want to make the surface stable, cauterize the puncta, make sure that it is healed, and then take the patient up for cataract surgery, especially if the patient has such severe dry eye that you are looking at cauterizing the puncta.
And that, in fact, use of topical steroids and doing a dry eye evaluation itself, the topical steroids can actually mask the signs of dry eye evaluation. So whether it's doing the examination or doing the cautery, it's best to stop the steroids and then do it to ensure that your cautery works in these patients.
So I think, Geeta, not using topical steroid in dry eye, I don't think I would totally agree to that we should never use topical steroid in dry eye. I mean, maybe as you said, like there would be a role of cautery. Similarly, I guess same in a way, there is certainly role of punctum plugs also. Whatever works in your hand, none of them is permanent. None of the permanent plugs are permanent. Even cautery can recanalize. Cautery works out quite economical for patient as well as hospital. You cannot sort of forego the treatment cost of punctum plug, and when they sort of dislodge in a few days, somebody has to bear the cost. So frequent such kind of thing, and especially when we are doing punctum plug without sizing the puncta and anything, that's totally absolutely absurd, and that does not have any value. So if we want to do it, has to be properly methodically done, and it certainly can have longevity, but otherwise, as you rightly said, cautery, and especially as you were indicating, that if you're using, say, element like cautery, filament like cautery, when we go inside and we start seeing the puckering, we start seeing the punctum going in, and then we start seeing that eschar. That's the time we sort of come out and stop it. Some people do use the regular bipolar cautery and pinch the puncta. The only issue is it becomes very superficial, and they recanalize much faster and much earlier. They may do it quite frequently, but I still think, or some people do use filament cautery. The filament doesn't go down enough that handheld pen cauteries. if it doesn't go down enough, as you rightly said, then it's just a question of time. It recanalize very fast then.
The
Absolutely
other thing
agree with Manchu about the use of steroids. They are very important in our armamentarium. But I believe that you need to use them judiciously, because if you don't treat the dry eye and you keep using topical steroids, then you end up seeing these patients who come to you with either glaucoma or cataract because of the long use of steroids, where all that the patient would have required would have been a punctal occlusion.
100%.
So it's just a judicious use of the various modalities that we have.
Totally.
The other thing that I would just want to add is, whenever you're doing a cautery, I would definitely want to see the patient the next day and document in percentage wise how comfortable the patient felt. Look at the surface, look at your clinical findings, and ask the patient whether it is 20%, 50%, because day one, you know, it is closed. 1 month or 6 months later, it might recanalize. So you can tell the patient, this is your comfort that you will have. If you still feel uncomfortable, then I would need to go to the next level, where I would look at either doing a prose lens or doing a tarsorrhaphy. So assessment of the comfort post cautery is very important for you to plan the next step, rather than wondering when he comes back after, say, 6 months with one of the puncta open, where you're not sure as to how much benefit he got with the cautery.
No, I think we use cautery a lot more less as compared to everyone here. And we, like Himanshu said, we use, I mean, I don't know whether he uses more, but we use punctal plugs more than using punctal cautery. And even in the severe cases, it has no role, like Steven Johnson, etc. The puncta is already steno, so you can't. There's no point using there. But it was very useful to discuss that punctal cautery is being used so widely.
One question is about pilocarpine, oral pilocarpine in primary Sjogren's. How do you prefer, and what's your opinion about oral pilocarpine? Bhaskar Geeta?
So we've not, I mean, we used to use it earlier, but its effect is more on the oral secretions rather than the ocular secretions as such. There was an issue with the availability also in between. There are side effects because of gastric upset, because of a bit of tachycardia that the patient feels. But if the patient has significant sicca in the mouth, then it definitely works. Ocular, we've not really seen a significant improvement as far as the Schirmer's value is concerned. No.
True.
And
so I have similar.
So oral pilocarpine I have seen in Moorfields when I was there. They use it very frequently. In fact, it was from there I picked up. But the only problem is the patient has more of systemic symptoms. There will be increased amount of sweating, etc. So people can't use it for too long. That is the only problem with it. So
same time, Dr. Namrata, there are people who really swear by. So our patient, what happens is, as Bhaskar said, if somebody has dry mouth, they really freak out on that. They really want to use it. We do start with something, though 4 times a day, up to that you can go, but the drooling becomes too much. So we start with 3 times. We tell them, you reduce yourself based on how you feel comfortable. Because sometimes they feel that too much of drooling is socially inhibiting, or sweating too much is. And many patients are like, they are using once a day and they really don't want to stop them. They say, no, I'm very comfortable with this thing. Are they all of them getting as much ocular benefit? I really won't say. Their symptomatic relief, irrespective of whatever we are seeing, is little better than what we are measuring. But primarily, somebody who has dry mouth, that's where it does the magic.
I think it's
the app was something that Bhaskar did mention about the application. In fact, it helps us monitor these patients, and most importantly, our residents and our fellows find it very useful, because it absolutely ensures that you don't miss out on anything when you're evaluating these patients. None of the dry eye mimics get missed out, and you have a very detailed and documented evaluation of these patients. So that's something that we've really been enjoying using over the last couple of years.
So Geeta, it's available to everybody?
It's available to everybody.
And it's like, do we
Point of sorry.
do we have to enroll? I mean, we have to pay for such.
So at this point of time, it is available free, of course. Over a period of time, we will probably need to think of a very minimal annual subscription just to be able to maintain the application website. But other than that, at this point of time, it's absolutely free of cost.
So we can actually try it out. I mean, from the website, if we can download.
In fact, a lot of we do have quite a few ophthalmologists who are regularly using the application outside of Shankar Nitralaya. A lot of our alumni also, and the response and feedback that we've got is quite encouraging and promising. So just have
Could
to
you
log
just
on
share it once again on the chat?
Yeah, it's ocularsurfaceportal.in.
Dr. Geeta, so can we use the app on the desktop? Like, does it open in a browser also, or does it?
Mention it's a web-based application. It is not a phone-friendly application.
Okay.
It is something that you can use only on a desktop or a laptop. And you need to register onto the site, after which the administration permits you to start using it. As far as patient confidentiality is concerned, because that is something which is a cause of primary concern for anybody who uses the application. The administrators don't have any access to the patient information per se, and have access to only the demographic information and the clinical parameters. Otherwise, the information is completely masked. It is on the cloud, which is another concern for anybody who uses patient-related data. It is HIPAA protected. So it is, we have a legal team that has ensured that it is absolutely, tamper-proof, and it is protected with the HIPAA, which is the standard of protection of patient personal data in both Europe as well as the US. So it's on par with that, and it's on the Amazon Web Services.
The app looks fantastic, and I think it's much easier to use it when it's on desktop browser mode. Also, it's easier for us to upload the files and then.
Yes, the other concern is about duplicating the entry because there is no way that we can link it with the electronic medical record, because all of us use different EMRs. So there is sometimes the concern of a duplicate entry in your EMR as well as on the app, but within a week of use, it's actually very fast. You don't really end up spending too much of time. And for those who have the luxury of having an optometrist resident or fellow, you can fill up part of the initial investigations and you just do the final. It doesn't take more than 5 minutes of your time. So anybody interested can please reach out to us. I think the basket, if you enter it on the chat, I will, otherwise I'll enter it, or you can always reach out to one of us.
I think if we are done with most of the questions, shall we just, wrap up, Dr. Himanshu?
I think you're the boss. You can wrap up. Such a wonderful session.
We had such a wonderful.
I mean, it's really heartwarming to see so many people attending on working day, and really nice. I really enjoyed.
So at the end, I would like to thank all the submitters who have submitted all the interesting cases, and especially those ones which we put into even potpourri without letting them, speak for their cases. Dr. Saujanya and Dr. Sujata, and all our esteemed panelists, and all the CSI, executive committee members for putting in, their valuable inputs. Dr. Bhaskar, a big, thank you to all those, last moment things. And again, thanks everyone, and even the Hallmark team for, letting this session go very, seamlessly. So everybody have a good night, and we see you for next, Kera Grand Rounds.
And before we go, an invitation for KeraCon 2022, 9, 10, 11th December. You can start registration. It's open now. And see you all there in KeraCon 22.
Thank you, Paras. I think it was a very good idea to start this Kera Grand Round. And it is doing really very
That
well.
was a
Very
brainchild of, Himanshu, but it's in fact, people love case-based discussions and a bit more practical.
I think Rajesh Pugla had said this thing and he had insisted we should do, and we must thank him for that idea. And Paras is really doing wonderful job coordinating with so many different people, and it's not an easy job, but it's really nice to see that.
In fact, it's nice to have, people from different institutes and even a combination of institutional based consultants as well as private practitioners. So it turns
just
out to
for
be a very good combination.
Just to put it across, informally, we have kept it in a way that we have one host institute who is sort of taking the lead, and then the other people join in, so that we can have like physically how we hold the grand rounds in institutes, different places. That's what we are trying to replicate virtually by having one host institute every time.
It's a good opportunity for all the fellows and residents to present their case.
Right. Okay, thank you.
Thank you. Good night, everybody.
Thank you so much. Good night.
Thank you. Good
Thanks,
night,
Himanshu.
everyone.
Some of you see you tomorrow.
Bhaskar.